Sir, good morning.
Good morning.
Thank you for joining us.
Thank you for having me.
Of course. So I usually like to lay some sort of foundation before we get into conversation. I think that it allows people to open themselves up to some of the conversations we would be having. And some of the things I use in laying the foundation is providing statistics, so people understand how very significant these diseases are. So diabetes, of course, is a prolonged disease that affects certain people, which you would understand the class of people that can be affected by diabetes. But globally, as far back as 2019, an estimated 537 million adults are living with diabetes, and this is according to data from the International Diabetes Federation. Is one of the ninth leading cause of mortality globally, and this is in 2020. And 2 million deaths annually are being attributed to diabetes or kidney disease that came about from diabetes. And unfortunately, Nigeria happens to be one of those sub-Saharan African countries that have people suffering from diabetes, and it is cause for concern, like I said before, because of the fragility of our healthcare sector, unfortunately. So let's start by you first giving us the medical definition of what diabetes is, and then if you would also like to speak about why you think there's such a high prevalence of diabetes in this part of the world.
Okay, thank you very much. So to define diabetes, speaking of diabetes mellitus, we define it as a chronic progressive disorder that is characterized by high blood sugar. We call that hyperglycemia, which is either due to complete insulin deficiency or there is no production of insulin at all. So the primary risk factor that concerns us is being black. Being a
already
black
opens you up to this.
that it already is a risk factor to coming down with diabetes. So that's why we find a lot of it in sub-Saharan Africa. We're black.
I mean, it makes sense for why there's this it's so high in this part of the world. So like you said, it's something that has to basically do with blood sugar, the balance of your blood sugar. Just to summarize it for the sake of those who don't necessarily have medical knowledge, and these terminologies might be confusing, but basically let's just say that alterations in your blood sugar and what have you is what diabetes means. So I'd like to think that diabetes is broader than that. There are types of diabetes, and maybe these things even inform the severity of the disease and how it affects the person. So let's talk about the distinctions between the type of diabetes, and if there are any similarities as well, you can point that out.
Yes. Okay. So there are, from the definition where we say it's either due to insulin deficiency or insulin resistance, the two major types of diabetes mellitus comes out of there, and we call that type 1 and type 2. Type 1 is when there's an organ in the body called the pancreas that secretes insulin. Insulin is what regulates blood sugar. Now, when these cells in the pancreas are destroyed, there is no insulin being produced. So basically, there is an absolute insulin deficiency. That's where you have type 1. Type 2, yes, there is insulin production, but insulin is not being allowed to work where it can work, which is in the cells. So there's insulin resistance or utilization of insulin, to use a simpler word for it. So that's what we call type 2. Now those are the two major broad types of diabetes. Now there's also gestational diabetes that's separate from these ones.
That's more in pregnancy.
And that's in pregnancy. So that's why we don't classify it really among those two.
Right. We actually have a mother and child show. There's a medical show that strictly talks about things like this with mother and children. Maybe one of these days you could join us for that one, and then we could focus on gestational diabetes. So yeah, you've defined it for us. You've basically spoken about type 1. Your pancreas is unable to function properly and produce insulin, so there's a deficiency. And then for type 2, this is when it's available, but it's not, should I say, it cannot be used the way it's supposed to be used, so that's resistant. Is there one that occurs commonly more?
Yes.
So which is it and why?
Type 2, and that's basically the one we find more in adults. The statistics have it that up to 90 to 95% of people that have diabetes come down with type 2, where there is some insulin being produced, and then the issues are that it can't be used properly, probably due to the fact that for you to have type 1, mostly is what we call autoimmune destruction of the cells. So that's not a common disease. That's not a common thing we find in people generally. So is mostly type 2, up to 95% of people. So that's the major thrust of what we are faced with in Africa.
All right. Please be aware this is not just a conversation for myself and Dr. Shodipo. We definitely want you to call in and talk to us about, your experience with diabetes, if you're suffering from it or you are caring for somebody who has diabetes and you want to talk to us about what the process has been like for you. You have questions, you want to have more understanding about probably certain signs and symptoms that are starting to manifest. You can call in 0913 6000 410. Now there's the WhatsApp line, there's the text. You cannot call in, I apologize. We will not be taking calls across any of our shows for today for reasons that you very much understand. So it is strictly WhatsApp or text messages. WhatsApp messages 0913 6000 430. That's 0913 6000 430. So you send your WhatsApp messages on there or your text messages. We cannot take phone calls for the rest of the day. Thank you for understanding. So I think that from the definition of the type 1 and type 2, one can very easily put together the causes of diabetes, but just for conversation's sake and for simplicity's sake, what are some of the most common known causes of diabetes?
Okay, yeah, so the first thing is to first clarify that there are no causes using that word, but again there are risk factors that predispose people to having diabetes. The first one, like we mentioned, is
being black.
Nothing you can do about that. But of course, there's also there's the genetic component to it. So some people, just by virtue of the genes they have, can come down with type 2. Some people, they have family history, and that's part of why anybody that comes to me, one of the first questions I ask is, please, because
you
sometimes
have a
you don't
history
even know
of diabetes
your
in the
dad,
family.
your mom, your aunt, your uncle, did anybody ever mention that their sugars were high at a point in time? Another risk factor is high blood pressure. So if you've been told you have high blood pressure, you have to also be watching out for diabetes. Obesity. If your body mass index is on the high side, over 30, pushing 35, yes, you are predisposed to having diabetes. If you have a high blood cholesterol, that's a blood test too. There is also a predisposition to having diabetes. And then, of course, two that I'm really passionate about, poor nutrition can contribute to the development of type 2 diabetes. And then physical inactivity. Sit down all day, don't do any exercises, generally don't move around. Over time you can be predisposed if other factors are lining up to having type 2 diabetes.
All right. Well, being black, I don't think we can't escape it here in sub-Saharan Africa. So let's just say pretty much every African there's a possibility that every black man would have diabetes. But then there's some things, maybe lifestyle decisions that would most likely further push up your chances of having diabetes. Like you said, poor nutrition, people who are docile, who don't move around a lot, obesity, high blood cholesterol, and high blood pressure, some of the risk factors that would most likely predispose a person to having diabetes. So I think that that can lead us to the signs and the symptoms. And I like to pay a lot of attention on signs and symptoms because there are many diseases that mimic the same symptoms. Like you see symptoms manifesting and you self-diagnose and think this is what you have, and then you start to self-medicate, and at the end of the day it's too late before you realize. So what are some of the most common signs and symptoms, maybe signs and symptoms that are somewhat peculiar to diabetes, that would point a person in the right direction and seek medical help? What are these signs and symptoms?
Okay, so there are three we call classical symptoms. When we in the medical profession see these three, sometimes together, sometimes just one or two, our hairs stand up. The first one is polyphagia. What that means is you're hungry, you eat, and then 1 hour later you're hungry and you're eating, and you just find yourself needing to eat and eat and eat. And of course it wasn't like that, and then suddenly you're having that. Okay, the next one is polyuria. What that is you are going to pee a lot, and you're having to pee a lot even when you're not drinking the amount of water normally that would lead to that amount of urination. So that's also a problem. And of course weight loss. Anybody that is having significant weight loss, you've lost 5 kilograms in the last 3 months and there's nothing in particular that contributed to that, then those are classical symptoms. Now the other symptoms.
The one you said, polyphagia, is that how you
Yes,
said it? Okay,
yes, polyphagia.
you eat but then you're never satisfied.
Yes.
I was about to make a joke, but my colleague would be so pissed if I do that. So let's move on. Polyphagia. Yeah, what are the symptoms?
Yeah, polyphagia, polyuria, weight loss, and then of course the last P is polydipsia. That's where you are just thirsty, and then you need to drink water, and then you are just thirsty, and I'm having to drink a lot of water, and I'm thirsty after 30 minutes, after 1 hour, and I drank a bottle of water, and by the time you are done, you've drank 6 bottles of water, and you're thirsty. So those are the 3 P's: polydipsia, polyphagia, polyuria. And then we tackle weight loss. Significant weight loss over a period of time those are common symptoms. Now, the biggest thing about diabetes is that most people are not quote unquote lucky enough to have these symptoms. That's why we call it a silent killer. Most people come down with complications of diabetes as the first signs that they are diabetic. And at that point, we are already, the horse has bolted and basically we are chasing it. So most people are not lucky enough to have these symptoms and to quote unquote catch it early. And that's why the signs and symptoms can be tricky in diabetes, especially because most people is when it's already on the way that they now go to the hospital. And I've been feeling this way, I've been. And what we're going to discuss is one of the cardinal issues.
We'll get to that. I'm actually glad you opened up complications, because diabetes in itself is somewhat life-threatening, but then if left unmanaged, of course, but then it also has the possibility of opening up a person to even more health issues, and these are the complications. So would you like to maybe highlight some complications, or should I say diabetes-induced complications that a person might experience?
We tie the complications of diabetes to blood vessels mainly, because it's high blood sugar. Blood is in the blood vessels, so everywhere blood flows through in your body has a high chance of coming down with a complication. Now, we broadly classify it as acute and chronic, but I'll focus on the chronic. The acute ones usually happen to people that are already registered diabetic and they already have some sense of that, and that's diabetic ketoacidosis and hypoglycemia as the more common ones. But I'll focus on the chronic ones. That's the small blood vessel issues and then large blood vessel issues. So small blood vessel issues are, for example, the kidneys. So you find somebody, kidneys starts giving issues, or they're not making enough urine and all that. That's called diabetic nephropathy. So that's where that comes about. And then sometimes, like I said earlier, is when the kidneys are already quote unquote packing up that we are finding out that this person was diabetic since, and of course didn't know about it. So that's the kidney. The second one is the eye. That's retinopathy. That's when the small blood vessels in the eye start to give issues at the back of the eye, and then suddenly there's development of cataracts, glaucoma, and eventually blindness. A lot of people, again, probably because of our wellness culture that isn't fully established, people are not starting to get better. Exactly, starting to get better now about checkups. They don't check their eyes and all that. It's when they are quote unquote going blind that they check, because every eye center where they see that, they'll check your blood sugar. It's routine, it's standard, and then find out that that's it's diabetes that caused these eye issues. The last one, for the small blood vessels, it's the neuropathy, and that's when the nerves are being affected.
Yeah, we're actually going to focus on that one. So basically, complications with the eyes. I'm sorry that I keep trying to, I'm just trying to simplify it, because yes. I do the best I can to make sure that people understand. They might not necessarily be able to check these terms and check their definition. So basically, you can have complications with your eye where you start to feel like you can't see properly, and then kidney diseases as well are some of the complications attributed to diabetes. So let's actually move to the primary focus, which is diabetes neuropathy, and that is something that has to do with nerve damage, from what you said so far. So let's talk about that. What is the relationship between diabetes and issues with your nerves?
Okay, yes. So like I mentioned, the small blood vessels in the body, every nerve in the body has its own blood vessel supply, has its own blood supply. When that blood supply starts to fail, to use a simple term, the nerve, which is what is feeding, that's where it starts to go bad. And the peculiarities about diabetic neuropathy is that it usually starts affecting people at the ends of their bodies. That's the feet
The
and the
limbs.
hands coming upwards. So that's the tie of it. So once the blood sugar is high and is high long enough and it is high enough, you find that the blood vessels to the nerves start getting affected, mostly starting from the feet. In most people, some people start from the hands, but mostly from the feet, coming upwards with different symptoms.
Yeah, I want us to talk about the manifestation. You know, we've used the word affected rather loosely. Your limbs will be affected, but what are what are the manifestations like? What would happen? Is it that you won't be able to use your arms? What exactly does it feel like? What's the experience like?
Okay, yes. So the common first experience is, let me use the loose term for it. I learned while I was working in Loma. It's baja baja, and that's it's it's a Yoruba word that captures the experience of that sensation that they have. Now, what a lot of them may not have known. Now, the other causes, but what of them may not have known is that one of the things that can trigger the baja baja
It's diabetes.
is diabetes.
Right.
So there's a feeling sometimes of a tingling sensation, just a mild electric shock happening at the big. Some people start at the big toes, spreads around the toes, starts to work its way down into the foot and all that. So there's that tingling sensation. Some people, there's a feeling of like they're just wearing the thick stockings and they can't feel much, and that's numbness. For us, that's a bit worse, but that's a common symptom it can start with. Some people, it starts with pain, actually. They just feel pain, especially at night. They'll tell you when they get up from the bed, once they put their feet on the floor,
It hurts.
it hurts. And they've been noticing now, unfortunately, we live in a society where a lot of people just reject things.
Yeah, it's
Not my portion and all that, and they just keep going and willpower and not realizing that that's already a complication. You may have diabetes, and this is the way it's presenting itself, as it were. So those are the most common ways this diabetic neuropathy shows up.
Is
that tingling sensation.
does it ever get to the point of complete loss of sensation? Because
yes.
I also want to understand how severe it might get, and also what stage of diabetes do you think that it can get to neuropathy? Because we'll definitely get to management of diabetes, but then is it during the early stage? Is it until the kidneys start to damage completely? At what point in the diabetes, I don't want to say experience, but then at what point do you start to see diabetic neuropathy manifest in a person who's affected?
Yes, so usually starts coming out when the diabetes is poorly controlled. Now, when we say poorly controlled, it means your blood sugar has been very high, sustainably high for a long period of time. We don't classify anybody as diabetic, so your fasting blood sugar is over 126 scientific term milligram per DL. Now, when you find somebody that's shooting 180, 190, 200 fasting, they may not know it. Again, like I said, silent killer, as I called it at first. And then those type of people, when it's poorly controlled, the blood sugars are that high for that long of a time, yes, they can come down with these symptoms that can come up. We've had somebody associated with our center that the bottom of the foot peeled off,
And they had no idea.
and he didn't know that the bottom of his foot had peeled off. So you can lose sensation to the point where a nail goes through your foot
And you have no idea.
and you have no idea, and the nail is sitting down there.
I mean, doesn't that open them up to infections? I don't want to be too far, because if you're not aware that you have an injury of such, so can that be some sort of, should I say, complication that can be
Yes.
associated with diabetes?
Of course.
Infections.
In fact, it's the most common one. That's infection. That some people now realize that, okay, I think I can smell something, and they don't realize that it's their own foot.
That's rotted.
That's
No
going-
sensation whatsoever.
And they may have no idea at all.
I mean, so there's a possibility that the person could actually die from an infection, not even the diabetes in itself.
Yeah.
Okay.
And I mean, that's what we call sepsis. By the time the infection
blood
sits
infection.
in the body long enough, of course, that's what will kill you even faster. And of course, what these wounds that can happen in the foot can cause is ulcers. And then some people, and then that ulcers, when they are there long enough, poorly managed, that's where you hear of amputations. Diabetes is the number one contributor to non-trauma, as in not that you had an accident and they had to amputate your foot. Diabetes is number one.
I mean, we're going to talk about mortality rate now, because I think that ushers us into the mortality rate. I really want to know, how often do people die from diabetes? How often do people die from the complications of diabetes? I'd like you to create that, distinction between the two.
Yes, so the distinction is that people die mostly from the complications of diabetes. For example, the other side of the complications I didn't talk about is the one that affects the larger vessels, the heart, the brain. You have a stroke, diabetes. You have a heart attack, quote and unquote. It's diabetes. Those are more common ones that people it just slumped. You may not know that it was diabetes and that was the heart attack and as it were that happened. So that complication is what kills. Now, when it comes to mortality rate, what the figures give us is that for every 100,000 people that die, 33 people died because of diabetes. Diabetes kills 11% of people that die every year. And this was the last 3 years, 11%. And Africa is contributing almost 7% of that. So, and the reasons are not far-fetched. Poor care, late finding out. By the time you get to the hospital, there's really not much they can do at that point. The horse has bolted. So those are now the issues that come about from there.
If you're just joining us, we're having a conversation about diabetes and its complication. Our primary focus being on diabetes neuropathy. Dr. Oluwaseun Sodipo is with me here in the studio. My name is Sage Babalola. We've told you what diabetes is, and we've tried the best we can to simplify it for better understanding. Basically, should I say, irregularities in your blood sugar. We've told you the types: type 1, type 2. 1 is resistant, and I think 1 is
Visualization.
Exactly. I'm trying so hard not to use the terminologies, and that's why I'm getting thrown off. Basically, you're able to produce insulin and you're not able to use it, which happens to be one of the most common types of diabetes that we see. And there's one where you're not even able to produce insulin at all. Your pancreas is supposed to produce insulin to help balance out your blood sugar. So insulin deficiency, which is type 1, and then we have insulin resistance, which is type 2. And according to the doctor, type 2 happens to be the most common type of diabetes that manifest in people, especially in this part of the world. And when we conversed further, we saw that the risk factors, well, first things first, once you're a black man, you're an African, there's every possibility that you can suffer from diabetes. And the risk factors, there's some that of your blood pressure is also something to consider. Obesity, that is your weight, is something to consider. There's also the issue of being docile. You don't perform physical activities, you're always sitting down, you don't move, you don't move around at all, no exercise, nothing. And there's also the issue of poor nutrition. And you see that aside from being a black man who can be predisposed to diabetes, these risk factors are also things that happen a lot in this part of the world. We don't eat for the nutritional value, we eat just so our stomach will be strong. Forgive my choice of word, that's the only thing, just so that you are surviving. That's why we eat. We don't eat, we don't check how much protein have I consumed today, how much carbohydrates have I consumed today. We don't care. As long as the stomach is strong, we're good. And then there are a lot of, no offense to the older people, who would sit down and ask you to pass the remote 190 times a day. They will not stand up to get even the remote. So you see that being docile, not wanting to go anywhere. You have kids that you can send on every single errand is actually predisposing you to diabetes, coupled with the fact that you're black and you don't even eat right. So I think that we should encourage physical activities in older people. I think young people nowadays move around a lot. That's one thing that has been established. So we've also spoken about diabetes neuropathy, which basically affects the nerves. It can get bad to the point where you lose sensation in your nerves, you have injuries on your limbs, and it opens you up to infection, which the doctor has also established to be one of the complications. In fact, it causes more death than diabetes in itself. So it becomes a medical concern when it gets to that particular point. And the illustration that was painted by the doctor, there are individuals who are losing parts of their limbs and they have absolutely no idea. And now we've spoken about mortality rates, that we contribute almost 7% of the deaths that have been attributed to diabetes. So let's talk about the treatment and management. I don't know about treatment per se, because if you say you're treating something, that means there's a possibility that it can be cured, and I don't think we've made any medical success to the point of finding a cure for diabetes, unfortunately. So I think it will mostly border around management of the condition. So talk to us about what management of diabetes is like.
Okay, so to start with, again, that there's no cure. I think we always need to establish that there are many things being pushed. This will take care. No. There is no cure. If you come down with high blood sugar, what we can do is control it and slow down. Part of what I defined it as is a chronic progressive disorder. What the word progressive means is that it will continue to stay and continue to do its harmful work. Now, the point of management is to slow down that progression enough so that by the time you are 98 and going home to be with the Lord, the progression is just slow. And I mean, whatever was going to catch you in terms of complications can catch you. That's progressed, but hey, you're fine, you're good, and that's what's going on. So the first port of call in management is lifestyle adjustment. I mean, I'm glad to be on the lifestyle radio, so that's a language that we speak here. So what that speaks to is physically diet, exercise, and healthy behaviors. When I mean healthy behaviors now, for example, sleep. I mean,
I don't know about people don't sleep now. To be honest, I don't think anybody completes an 8-hour sleep cycle nowadays. I don't think so. I don't.
I accept. I mean, medical school.
You're a doctor. I mean, come on. You don't sleep 8 hours. No, you don't sleep 8 hours. Come on, it's not possible.
No, I do not.
Yeah.
But really, I always say it. If I can get 5, 6, maybe I'll look the other way. Really. So that's what I mean by healthy behaviors in terms of sleep. And Nigeria, I mean, yesterday apparently a lot of people in traffic getting out of Ikeja, and because some people go home by 11 and 2 a.m. and I mean, just downstairs, someone was talking about that. They go home at 2 a.m.
Yes.
I don't have to be a back at work.
Of course. We resume together. I know what you're talking about.
So that sleep is part of it. And those are the things that can help you manage these things. Now, diets, I mean, it's
also a problem.
It's also a major problem.
I'm guilty.
Because we just was available. Let me get that, and I keep it moving. And the thing about diet is because it doesn't have any harmful effects today, you may not have the sense
it's
that
more long term.
Exactly, it's cumulative because diet contributes to everything else. High blood pressure. They call it the DASH diet against hypertension. So it's those things that cholesterol, 3 of the risk factors inside what can push you towards diabetes is diet related. So we always push. I mean, we have part of what we do with my center, Chronic Care, is we always push dietary adjustments from your first day. Part of your prescription is you need to see our nutritionist. Part of your prescription is a fitness/exercise plan. Now, because most people that find out that diabetic are a bit older, what we found out is that this age thing that is when you're getting older. We have a 22-year-old patient, we have a 25-year-old patient.
Is that common though?
Yeah, we are finding them more commonly
in
now.
Younger people.
Yes, in younger people, because of the westernization of our lifestyles. Oh, we just eat this, and then not to name many names, and it's fast food, and because you have to just keep it pushing. That's the pace of work. There's nothing you can do. And if you already have those, maybe family history, you're already black. So you're already taking 2 in that box. And then by the time you add not sedentary lifestyle, you're coding all day, you're in front of the system for 8 hours straight, you're already piling on the risk factors that can trigger what was hidden, quote unquote. So that lifestyle, that dietary part has to come in. And then, of course, exercise. When we say exercise, yes, we push for 150 minutes of exercise every week. But we understand. And trekking is not exercise, please. If you had to trek last night, sorry to break it to you. I'm sorry that Lagos happened to you, but that's not exercise.
We moved.
You have to be intentional. You have to be intentional about it. So, why we say 150 minutes? I mean, because a lot of people have bad knees or something, the older people, I always tell them, but you can dance. That's activity. That's exercise. When you're dancing in church on Sunday and the praise and worship is hitting, that's exercise. Can you please stretch that out? As a big they say you should be thanking God every time. Can you please stretch that out into your own personal life and put it into the exercise that you are doing? And that becomes part of that becomes the first basket, that lifestyle modification. Because with that, then the medical intervention now starts to come in. Because we don't intervene unless the high blood sugar is high enough for us to say, okay, no, we can't just use lifestyle. We have to put you on.
Oh wait, so can there be something like a pre-diabetes stage?
Oh yes.
So when a person is in like that pre-diabetes stage, you don't necessarily recommend medication, just lifestyle changes. Oh, okay.
Yes.
Okay.
And the first thing about pre-diabetes, I mean, for example, in Nigeria, they say there are about 4 million diabetics. We believe there are way more than that.
They say.
That's wrong, man. But pre-diabetes, they are in Nigeria. At least, and we don't know if it's correct. It might be more. More than 15 million people.
How many of us are
already
here?
Pre-diabetic. They're already knocking on the door. It hasn't just opened. So those people at that stage is lifestyle modification. These ones are free. You don't have to buy them. I mean, unless you subscribe.
I have to buy the food now. You don't understand. I should be eating
you
my diet.
you might as well have a few
eat
more.
right.
Exactly. That's how have a few more veggies. To what you're doing. So then we're now going to the medical part of it, which is mostly oral tablets, oral drugs, and then injectables if need be. Now, type 1 people, you must take injectable, which is insulin. Type 2 depends on the presentation and how bad the control is. Then we might need to put you on injections.
So for those who have the deficiency, we might have to put them on injectables. It's necessary. They can only be on injectables, but for those who are resistant, then oral medication
first, mostly, and then if it's real bad, we might need to add on injectables to the oral they're doing. Now, for everybody, lifestyle adjustments are the baseline management for everybody, because what we're trying to do is take advantage of the lifestyle adjustments you're doing with the medications we're doing, so it helps the medications that you're on to work.
Let me put this to you. Aside from eating right and everything, how about smoking? Those who consume high amount of alcohol and all of that, what role does it play in the severity of the symptoms or something like that?
Tobacco especially is another risk factor that I didn't mention ahead. So anybody that's diabetic that is smoking, to use the street step,
really?
So that one is stop. Now, alcohol, of course, that's a debate coming. That they say moderate. What does moderate mean? It's just some people, because my problem with moderate is some people's moderate is some people's drunk. So
that makes sense.
So I struggle with
what is your definition of moderation?
I mean, if you are taking half the bottle of Absolute and saying, but I didn't finish 2, and that's a win for you, that's not a win for us. So we have to have the conversation about, what does moderate alcohol? Yes, we're not saying stop. Red wine is healthy, that's why I'm drinking 3 bottles in a week. I mean, instead of glasses, the glass is the bottle. I didn't have glass, I drank the whole bottle. So that doesn't really follow. So when we say alcohol, our best bet is if you can stop. If you can't stop, let's bring it down to the barest minimum that we agree on.
But let's round this off with talking about success that have been recorded in managing diabetes, because really the prevalence is high, is really high, especially in this part of the world. And I keep saying this part of the world because who we are, our genetic makeup already even predisposes us to diabetes in the first place, so it makes sense that it will be really high here. But let's talk about success that have been recorded. You're in the medical field. I would like to think that, of course, you're aware of trends in the medical field, research regarding diabetes, how much progress has been made. Would you say that there's been any significant breakthrough of a kind in managing diabetes? Healthcare facilities, infrastructure. Do we have more hands working together to minimize diabetes in the country, at least from your own perspective?
Okay, yes. So I mean, I've been doing this for almost 10 years now. I would say over the last 2-3 years or so, probably since the COVID era, people have become a lot more conscious about fitness. For example, people have become a lot more conscious about eating right. So, and then you find more older people saying general checkup. So that's the win for us, because some of the things that we say that will help you manage these things are things that if we catch it early, just like for cancer, for example, stage 1, you can still, pre-cancer is best. Stage 1, we can still,
you can even fix it with surgery at the point.
So that's just it. Then you're talking, let's just manage you. So it's early presentation, early finding is always the best. I mean, for our center at Chronic Care, we did the crunch data and found out that people that came in last year at a threshold of high, 87% of them were good to normal by the time they had been through a year with us. 7%, I dare say, is a very high mark. So there's success if you help us help you in that sense. So that's where it comes from these same good old things.
All right. So basically, you're saying that to minimize the risk factors for diabetes, lifestyle changes is one of the most important things that we need to focus on, and what you eat and what you keep out of your system, like smoke, tobacco. You have to be very careful with that.
Yep.
And also, how about physical exercises? Like you said, 150. Is this the same for people of older, like the older people, or is there a different one for younger people? Is the time frame the same? How often do we need to exercise? Because younger people, I like to think that we are more, should I say, healthy. Let me use it like that. At least age gives us the luxury of, at least we're able to fight off certain conditions more than older people. So is it the same across board? Do we have to work out the same amount of time? Is our diet the same, or what you eat and how long you exercise is peculiar to what age bracket you fall in?
There's really no age distinction yet in terms of the 150 minutes, but we try to break it into, if you can exercise 5 times 30 minutes for 5 times, that's 150 minutes. But everybody has a different threshold. For example, now a lot of our older people, please, in your living room, dance. Some that live in estates, for example, take advantage. Now do your walks. Just make sure they are brisk walks, not that you are just strolling along, gisting about elections. That's not the exercise we're talking about.
All right.
So that's why I said intentionality. That you moved from here to the door and came back and said, yes, I logged 18 steps. I mean, not you have to go and use the bathroom. You can't really count that. So that's where that comes from in terms of. And then for diet, fruits for a 10-year-old is fruits for an 80-year-old. Vegetables for a 10-year-old is vegetables for an 80-year-old. It's quite the same thing. Now, when you're formulating that's why a professional is best to help you formulate it. You might now need to take in other factors. Somebody who is already obese, you have a different, you're chasing something else.
Minimize cholesterol and all that.
Whose BMI is 19 and probably would like to add a little bit of weight. So that's where the differences now come in to formulate what is now a management plan for each person. It's individual, no one size fits all.
No one size. Well, thank you so very much, Dr. Oluwaseun Sodipo. This was a very exciting conversation. I sort of thought that, the medical complexities of this was going to make it a very hectic conversation. Well, thank you for making it quite easy, and thank you for simplifying it and making it very understandable. We're grateful for your presence. So, final words to somebody who is probably dealing with diabetes, or those who are in the pre-diabetic stage and they have no idea. As a medical practitioner talking to people, what would be your final words to those who are listening to us this morning?
The first thing would be, please check. Everyone. It's now irrespective of age or how you live. Oh, I gym, I eat right. Please check. That's the first thing. If you check and it's normal, please get the figures that they said. Don't let the practitioner tell you it's normal. No, what is it? And understand that there is a range that you're talking about. Now, if you are pre-diabetic, you have to check more and do this lifestyle changes. And if you're diabetic, first of all, keep your head up. It's a long journey.
There's no cure.
There's no cure, but you can live with it like you didn't have it if you put these measures and integrate all these different things. Your medications, please take them. If you don't like the medications, talk to your doctor. Don't stop by yourself and say, I didn't like it, Joe, and I stopped. So these are things that work with us, will work with you. We want you to be well. That's why we were trained.
Right. Well, thank you so very much once again. I'm glad that I'm pretty sure somebody has learned a thing or two, and that you might need to seek medical intervention. Self-medication, I've always said at the end of every show, it does not help anybody. You're not a medical practitioner. You might not even be able to determine or ascertain what your signs and symptoms are telling you, because like we said earlier in the show, sometimes signs and symptoms manifest almost the same. You're not pregnant, you have malaria, and then you're already downing malaria medication when there's something growing in your stomach. So I always use that example because it's quite easy to relate. So don't self-diagnose, don't self-medicate. Most importantly, seek professional help. Change your lifestyle. Obesity is something that would be, especially in the, I don't know why it's not happening often. Like you see children who are 3 years old and they already weigh, I don't want to compare the child to an object, so they're bigger than they should be. And then there are people who are skinnier like me, which I don't think is a problem because I'm not obese, but it's not. End of conversation. I'm putting off your mic. Now, I know being underweight is also something that we need to consider, because being underweight and immunity, there are many conversations about that as well. Maybe we'll even have another conversation about it, and maybe when I hear the risk factors, I'll be encouraged to eat more.
Yeah, sure.
Right. Thank you so much for being here. My name is Sage Babalola. We had a conversation with Dr. Oluwaseun Sodipo. Until next week, Friday, 10:15 to 11 a.m., where we bring to you another conversation, another health-related topic. We'll talk to you about the signs, symptoms, the management, and of course, how to minimize the possibility of you coming down with that particular condition. Don't go anywhere. This is Mainland 98.3 FM, the sound of Lagos.